Alright, welcome back for the second video on pancreatic cystic lesions. We're going to start with cystic neoplasms. This is a nice review table from a radiology website. And as we start talking about cysts, I'm going to throw out some buzzwords to remind you which lesions we're concerned about and which lesions we're less concerned about. So if you see a microcystic lesion with a central scar in an older female patient, you know it's likely a serous cyst adenoma. When you see a macrocystic lesion with peripheral calcifications that does not connect with the main pancreatic duct, and this is in a younger female patient, this is likely a mucinous cystic neoplasm. Whereas if you see a larger dilated main pancreatic duct with associated cysts in an older patient, and your gastroenterologist says that they see a patulous ampulla of Vater with mucin pouring out of it, that's likely a main duct IPMN. And finally, if you have a bunch of grapes and a mildly dilated pancreatic duct in an older patient, this is likely a side branch IPMN. This is the slowest part of the presentation, but I'll try to catch your attention with some of the highlighted text. We'll start with serous cyst adenomas. These are the most common cystic pancreatic lesions, and they are found incidentally on imaging and are typically found in the body and tail of the pancreas. Larger lesions are usually the only ones that become symptomatic, and the size cutoff for symptoms is usually somewhere greater than 4 centimeters, though can occur smaller. Serous cyst adenomas can be distinguished from their mucinous counterparts as they have that microcystic or honeycomb appearance, of which some of these lesions can have a central scar, and these are typically well circumscribed lesions. If the lesions are larger and can't be well defined on CT, then the patient typically ends up in the endoscopy suite for FNA and fluid analysis, which will show low CEA and low amylase levels. And as previously stated, there is no malignant potential in these lesions. Here's imaging and path showing the characteristic honeycomb and central scar appearance for these lesions. So mucinous cystic neoplasms are also fairly common in the world of pancreatic cysts, but unlike serous cysts, these will present in younger patients, okay, and are almost exclusively found in the body tail of the pancreas. Most often these are unilocular, and in about 10 to 20% of cases, these mucinous cysts can be harboring a malignancy. Additional imaging characteristics of these unilocular cysts are usually that they have thickened walls and possibly peripheral calcifications. These patients typically go down the endoscopy pathway based on the initial imaging characteristics, and they can be difficult to distinguish from IPMNs and oligocystic serous cysts. If there's mucin or if the CA is high, you know that you're not going to be dealing with a serous cyst on fluid analysis. And if the amylase level is low, you know that it is a mucinous cystic neoplasm as opposed to an IPMN, because the mucinous cysts are not connected to the main pancreatic duct. Most of these lesions end up being resected because of the high-risk features and concern for malignancy. And I'm just going to make one comment on the mutation status of these lesions, and that is that you can get them on RedPath, which is the genetic sequencing for these lesions from a program out of UPitt, and I think it is a cool technology, but I don't know how much it adds beyond the non-invasive test and fluid analysis that we've discussed so far. Here's an example of a mucinous cyst, though rather than the microcyst that we talked about with the serous cyst adenomas, this mucinous cystic neoplasm has cyst septations within it, as well as the calcifications that we discussed along the cyst wall. If you happen to get a biopsy of one of these lesions, or if you see it on your past specimen, the way to differentiate these mucinous cystic neoplasms from IPMN is because they have this pathognomonic ovarian stroma within them. A quick literature review to help us understand the malignant potential of mucinous cystic neoplasms. Crippa et al. Published this descriptive series in the Annals of Surgery in 2008 of 167 patients, which showed the already described features of these lesions, which again they occur most typically in females and occur in the tail of the pancreas. And when considering the malignant potential of these lesions, we know that older patients with larger tumors or nodules are more likely to have an invasive cancer. Quick interesting note on invasive cancers within these mucinous cystic neoplasms is that they typically have a much better prognosis than the pancreatic adenocarcinoma counterparts, i.e. these patients have a 57% 5-year survival in their invasive cancer patients. A larger series looking at risk factors for malignancy in mucinous cystic neoplasms with the previously stated described features for mucinous cystic neoplasms, again more commonly occurring in women in the body or tail of the pancreas, with a relative incidence of adenocarcinoma or high-grade dysplasia. And interestingly, in this larger series, we see a broader set of risk factors for malignancy in mucinous cystic neoplasms, i.e. those in men, those that occur in the pancreatic head or neck location, associated ductal dilation, in addition to the previously mentioned risk factors. So concluding thoughts on mucinous cystic neoplasms, you're either operating on these for symptoms or cancer risks, though the initial algorithm that we saw in the first video says you should operate on all of these patients based on a literature review. You may be able to observe smaller lesions with no high-risk features based on patient selection, and Dr. Kim will review some of these cases and features. All right, we're making progress, and we'll move on to intraductal papillary mucinous neoplasms. These can be hard to differentiate. From mucinous cystic neoplasms, but even though they may look alike on imaging from mucinous CA levels, there's a few features that will cue you in. First, these occur with similar frequency in men and women, so more men are going to have these than the MCNs, which we typically talked about occurring in women. The IPMNs are more common in the head than in the tail, again, so different because MCNs occur more typically in the tail. And if you have fluid amylase available, then you know that IPMNs are going to have a high amylase level because they're connected to the main pancreatic duct. If these patients have a biopsy, then there should not be any ovarian stroma. Again, the ovarian stroma is in the MCNs, not in the IPMNs. So a male patient with a mucinous lesion in the head of the pancreas more likely has an IPMN than an MCN. When thinking about IPMNs, there's 3 variants to consider. That's the main duct IPMN, which is the most concerning because of the high risk of malignancy, up to 60%. All of these have to be resected in the fit and appropriate patient. Branch duct IPMNs, which still has a significant risk of malignancy, but there are patients with side branch IPMNs who can be monitored. I'll start with some survival data on IPMNs associated malignancy. And there's 2 types of malignancies when we think about IPMNs. There's the colloid type that we think about when we say that IPMN-associated malignancy has a better prognosis than pancreatic ductal adenocarcinoma, and that's true. We see the survival curve up here for the colloid group. However, the tubular group, or the pancreatic ductal adenocarcinomas associated with IPMNs, typically have poor dismal prognosis. Looking at some distinguishing features of main duct IPMN, typically these occur in patients older than the mucinous cystic neoplasms and are associated with main duct dilation. Like mucinous cystic neoplasms, these cysts have high CEA levels, and the risk of malignancy is higher in main duct IPMNs than it is in side branch or in MCNs. Typical features, imaging features again, we see multiple cysts associated with a dilated pancreatic duct. It's difficult to find a series of images to show this in this PowerPoint, but the illustration shown here depicts it. So almost all main duct IPMNs are going to end up having operative management unless the patient is unfit or there's some question about the resectability. I think the interesting question with these IPMNs is which surgery to do and when to stop. This is one disease that may ultimately require total pancreatectomy if there are multiple concerning lesions identified. In most cases, you'll be able to decide between Whipple and distal pancreatectomy at the time of resection. Remember that you were supposed to get at least one frozen section. The biggest issue here when you ask your pathologist about the frozen section is to make sure that there is no cancer. If there's cancer in the specimen, you're going to need to take an additional margin and send that for frozen section again. Whereas if it's just high-grade dysplasia at the margin, take one additional margin, send that for permanent, and then you're done. Main duct IPMNs are one of the few times where you got to prepare your pancreatectomy patients for a potential pancreatectomy, a decision that you'll make intraoperatively based on the frozen sections. Side branch IPMNs are as they sound. They're mucinous cysts with the cyst located on side branches and with less main duct dilatation that we saw with the main pancreatic duct IPMNs. The side branch IPMNs have a lower risk of cancer. And these are mucinous cysts that can be observed if small and without high-risk features. For evaluation, I think side branch IPMNs are one of the times where MRI, MRCP are more helpful than pancreatic protocol CTs, in part because you can see the connection between these cysts and the main pancreatic duct, which will help differentiate them from mucinous cystic neoplasms. The concerning features for these side branch IPMNs are similar to the other concerning features we've talked about for mucinous cystic lesions, and those are your larger lesions with mural nodules, dilated pancreatic duct or progression of duct dilation on serial imaging, and if the radiologist sees any lymphadenopathy. Here's an algorithm for side branch IPMNs from Tanaka 2012. Basically, if symptomatic or if the duct is larger than 1 centimeter, or if you see a solid nodule, then that patient's probably going to be going to the operating room, as seen here. If there's a smaller or asymptomatic lesion, look for high-risk features such as larger than 3 centimeters, a thickened duct, or a thickened wall, a dilated duct from 5 to 9 millimeters, mural nodules, or changing caliber of the duct. If yes, then the patient's going to head towards the endoscopy suite for US and fluid analysis, and then consider surgery for any concerning features found on these. Otherwise, you can discuss serial imaging with the patient based on size. Solid pseudopapillary tumors, we'll talk about these briefly, and these SPNs are also known as Hamadi tumors. They're a rare tumor of the pancreas comprising only 2% of pancreatic cystic lesions. They most commonly occur in young females and typically require operative management due to risk of malignancy. So the patient that you'll see when you get asked about this type of tumor on the boards is going to be a 25-year-old female with a solid cystic mass and with calcifications. The imaging read may also include comments about internal hemorrhage or necrosis seen in the lesion. These changes occur within the SPNs as the solid components undergo cystic degenerations and form these solid pseudopapillary components inside cysts. Another distinguishing feature from mucinous cysts is that these lesions rarely communicate with the main duct. You can see some solid cystic lesions here depicting the cystic degeneration within the cyst. And we'll go over a few more of these. So, okay, a couple points on pancreatic pseudocysts. First, these cysts have to occur after an episode of pancreatitis. If you have a patient with a cyst and a radiologist calls it a pseudocyst, that patient, again, has to have a history of pancreatitis. EUS-FNA analysis should be performed on these lesions, and the amylase for these cysts should be high, as they are typically connected to the main pancreatic duct, and these cyst walls should be biopsied either intraoperatively or by the endoscopist. And again, you can these are pseudocysts, so there should not be epithelial cells in the walls of these cysts. So if you get a biopsy back on a suspected pseudocyst and it has epithelial cells, then it's not a pseudocyst, and you have to consider one of the mucinous lesions we've previously discussed. If you are going to operate on these patients, again, always get a biopsy of the wall intraoperatively to rule out epithelial cells in the wall. And then if they get a cyst gastrostomy, then when you're thinking about the type of surgery you're going to do on them, you're either going to do a cyst gastrostomy or a Roux-en-Y. If they get a cyst gastrostomy, you can usually do a transgastric approach. If you do a loop of small bowel, or if you use this loop of small bowel to decompress this cyst, make sure it is from a roux limb. As Dr. Fleming pointed out to me last year when he asked me the question, what type of small bowel loop would you bring up to this, he made the point to emphasize that you should not use a loop of small bowel that is connected to the BP or alimentary tract and have a separate roux limb to go up to it. If you do connect to the BP limb or to any food passing by, then that can contaminate the cyst and increase the risk of infection, and you have not really helped that patient operatively. Here's a summary slide from Blumgart's for anyone who wants to pause the video and take notes.